Anything wrong with the scalp or hair.
So first,
If the patient is wearing a hairpiece or wig, ask the patient to remove it. Inspect the hair, noting its quantity, texture, distribution, and pattern of loss, if any. You may see loose flakes of dandruff. Part the hair in several areas to inspect the scalp. Look for scaliness, lumps, nevi, or other lesions. Observe the general size and contour of the skull. Note any deformities, depressions, lumps, or tenderness. Learn to recognize the irregularities in a normal skull, such as those near the suture lines between the parietal and occipital bones. When examining the patient's face, observe it at rest and during conversation, noting facial expressions and contours, and observing for asymmetry, involuntary movements, edema, and masses. Assess the color and condition of the skin on the face, noting its color, pigmentation, texture, thickness, hair distribution, and any lesions. Inspect the area over the lacrimal gland and lacrimal sac for swelling, and look for excessive tearing or dryness. To inspect the sclera and the conjunctiva, ask the patient to look up as you depress the lower lids with your thumbs. Look for any nodules or swelling and inspect for color. Note the vascular pattern against the white scleral background. Ask the patient to look at each side and down. This will give you a good view of the sclera and bulbar conjunctiva. If you need to view the palpebral conjunctiva of the upper lid, the eyelid must be everted. With oblique lighting, inspect each cornea and lens for opacities. To do this, shine a pen light from the side. Next, test the pupillary reactions to light. First, darken the room. Then ask the patient to look into the distance. Shine a bright light obliquely into each pupil in turn. The oblique lighting and the distant gaze both help to prevent a near reaction. Look for the direct reaction, consisting of pupillary constriction in the eye being illuminated directly. Then, quickly swing the light to the other eye, looking for the consensual reaction, which is pupillary constriction in the opposite eye. If the reaction to light is questionable, test the near reaction in normal light. Testing one eye at a time, hold a pencil or your finger about 10 centimeters from the patient's eye. Ask the patient to look alternately at it and into the distance directly behind it. Watch for pupillary constriction with near effort. The extraocular movements, looking for the normal conjugate movements of the eyes in each direction or any deviation from normal, nystagmus, a fine rhythmic oscillation of the eyes, and lid lag as the eyes move up and down. Ask the patient to follow your finger or a pencil as you sweep through the 6 cardinal directions of gaze. Making a wide H in the air, lead the patient's gaze to the patient's extreme right, to the right and upward, down on the right, then without pausing, up to the extreme left, then upward. Test for convergence of the eyes by asking the patient to look at your finger as you move it toward the bridge of the nose. The eyes can usually follow your finger to within 5 to 8 centimeters of contact. Begin the examination of the ear by inspecting the auricle and surrounding tissues for deformities, lumps, or skin lesions. If ear pain, discharge, or inflammation is present, do the tug test to test for otitis externa or external otitis. Move the auricle up and down, press the tragus, and press firmly on the mastoid bone behind the ear. Tenderness here suggests mastoiditis. Examination equipment is within easy reach, including otoscope, tongue blades, and gloves. With the patient's health history in mind, and after good hand hygiene, you are ready for the physical examination. Begin by inspecting the anterior and inferior surfaces of the nose. Note asymmetry or deformity. Some asymmetry of the two sides is normal. Test for obstruction by pressing on each ala nasi in turn and asking the patient to breathe in.
Breathe in gently for me.
Then, tilt the head back, press gently on the tip of the nose, and shine a light into the vestibule to get a partial view of each nasal vestibule. To inspect the inside of the nasal passages, use an otoscope with the largest cap or speculum available. Be sure to appropriately. Conclude your examination of the nose by palpating for sinus tenderness. Press on the frontal sinuses from under the bony brows, avoiding pressure on the eyes. Then press up on the maxillary sinuses, forms the roof of the mouth. Before examining the mouth, ask the patient to remove any lipstick or dentures. Wearing gloves, inspect the outer surfaces of the lips for symmetry, color, and moisture. Note any lumps, ulcers, cracking, or scaling.
I'm just going to look inside your mouth. If you can open wide.
With good lighting and the help of a tongue blade, inspect the oral mucosa for color and ulcers, which can be seen in herpes simplex, white patches suggesting candida infection, and nodules. Note the color of the gums. Inspect the gum margins and the interdental papillae for swelling or ulceration. Also inspect the teeth, noting any that are missing, discolored, misshapen, or abnormally positioned. Untreated caries can lead to bacteremia and endocarditis. With your gloved thumb and index finger, check for any teeth that might be loose and lead to risk of aspiration, especially in older adults. Next, inspect the color and architecture of the hard palate.
Good, and if you can just give me a big
As the patient says ah or yawns, note the movement of the soft palate and uvula. The soft palate should rise symmetrically, and the uvula should stay in the midline. If the patient's tongue obstructs your view, use your tongue blade to depress it, but not so far that you cause gagging. Inspect the anterior and posterior pillars, tonsils if present, and pharynx. Look for redness, exudates, or ulceration. None should be present. Fever, highly suspicious of streptococcal pharyngitis.
If you can open your mouth and stick your tongue right at me. Good.
Continue by inspecting the tongue. Note its symmetry and color. Inspect its dorsal surface, which is normally roughened by papillae and sometimes covered by a thin white coating. Using a gauze square, use your right gloved hand to grasp the tip of the tongue and gently pull it to the patient's left to inspect the undersurface and sides of the tongue. Look for white or reddened areas, nodules, or ulcers.